Hey y'all, welcome back to The Long Defeat. Today we've got Dr. Lia Fiallos, a family medicine physician here in Denver, Colorado. We work together at the Stout Street Health Center for Colorado Coalition for the Homeless. She's a wife and a mother and has been doing family medicine. We just did the math for 14 years. Is that right?
Yes.
Nice. And today, I think the topic of our conversation will be mostly focused on medical missions. And we just talked about this. You started doing your first medical mission work in med school in 2008. What First, what was like the driving force, one, for you to go to medical school, and was that always in your view, in the crosshairs of was doing medical missions?
Yeah. I'm someone who really dragged their feet in regards to going to medical school. My parents were both medical and warned me not to go that path. I have a degree in anthropology. Um, some of it was archaeology, but mostly I was really intrigued by different cultures and learning about them. And I think once I started getting more into the social justice components, both here and abroad, I started kind of searching for ways where I could help people and more than just reading about their struggles. Um, so it still wasn't a straight line to med school. I think I know Ed brought up Paul Farmer. I think probably all of us in this line of work eventually bring him up in a lot of conversations. But reading a book by Tracy Kidder, Mountains Beyond Mountains, I knew right away that I couldn't do what Paul Farmer did. I mean, he's such an extraordinary person. But I was pretty intrigued by that type of work. And fast forward a little bit, I did make it into medical school, and the opportunity came up right before starting school, actually, to go with someone who would later become my advisor and mentor to Guatemala on a medical mission trip with some other students from another school. And after that, I was hooked. I mean, I didn't know how to put on my stethoscope when I got there, but years later, I'm going back helping out students. And that's just something that remains near and dear um, to my work as a physician and, you know, teaching tomorrow's physicians, I guess.
Yeah. I actually don't think I knew about your undergraduate degree in anthropology, which actually kind of fills in a little bit darker some of the shading of like the conversation we had before this, and how you think about the populations you work with. And it does make more sense of like the trajectory of you going. We've talked because of my application this last year. We've talked a lot about applying for med school and how pretty much straight up awful it is, um, and yeah, there is, I think, a deep why for many of the people who end up, not everyone who ends up in medicine, but it does seem like very many people, and probably the people I connect with the most. There's a deep why, uh, and thanks for sharing that with me. That's honestly very cool.
Mhm.
And that how has that background in understanding people and their cultures changed the way that you work when you walk into the room and talk with an individual? How does understanding where they come from and the struggles that they as an individual have, but the people that they come from, the countries they come from, how does that change the way that you treat them?
Um, I think a simple, hello, even, and I've a couple patients who've I've crossed in the last few years from Kenya or Tanzania and coming in and saying
Mhm.
Hujambo, si jambo back. Just kind of, you know, puts a little light in their eyes and has a good start to the conversation. I obviously will often need a translator to, if I'm very limited French, for instance, but I think just that first initial connection, like I'm interested in who you are, not just right now, but before this. I think that helps set up the rapport and just trust in the room from the get-go.
Yeah. I see that even um I know like a traditional greeting in Arabic. And so sometimes I'll like salam alaikum and then they'll just go into Arabic and I'm like, "Oh wait, it's just
Yeah.
it's just the one thing." Yeah.
Yeah.
Uh
Yeah.
and I
But I
see
think
it.
I think that's appreciated. Um,
Yeah.
I mean, even Spanish, which I can continue speaking, I see that just they they almost got like excited, not necessarily to be there, but that they can tell their story. And often my Spanish is not the same as theirs.
Mhm.
But just that starting off on the same foot to some degree is helpful, I think.
Yeah. I yeah, I don't think people would think about this from the name of the organization we work for, but we end up being the safety net for a lot of uninsured people. Um, and so we see a lot of the migrant population here in Denver. Certainly not all of the migrant population. There are
Mhm.
many other resources available to them as well. But I, my limited, much more limited than your Spanish, enough to do my job as a medical assistant, I have found it does give you some common ground and helps those people feel so much more human than alien when they're in the room with you. And I don't mean that in the undocumented sense. I mean that as like literally so different from you that you can't even speak the same language.
Mhm.
And so having some sort of common ground, even if they're coaching me on conjugations and they're like, no, say it this way, or
Absolutely.
pronunciations like on different words. It's I had a grandmother who she was teaching her grandchildren how to speak Spanish, and she was getting so excited and wanted to like bring me Spanish speaking like resources and
Oh.
teach me so much more. It was it was adorable.
That's great.
Yeah. Um, you mentioned Kenya and did you say Tanzania and a couple other places? How how do you with medical missions? Maybe this is more a picture into medical missions, but how is each country, I imagine, facing different difficulties, different struggles? How are those things identified and how are they met?
Yeah, I guess I can speak more so to Guatemala. Medical missions is something that my opinion of and just overall feelings while I'm there have really um, morphed and evolved, I'd say, over the past 18 years. I think as a student, you're excited to help. You are learning all these things you don't see at home. And you're also uh, learning different ways of diagnosing without all the things you have at home. And, maybe in a day you get to do like 3 knee injections, other procedures that you don't get to do very often. It's just like a neat experience for many reasons. And then there's the component of, are we really helping? Are we just putting band-aids on people? as the whole white savior complex, even though
Yeah.
I'm from this area. It's just like, what are we really helping? In Guatemala, the area I've largely gone to has been repeated every year, at least once, sometimes twice a year with this group. I've seen the same patients year to year, which is pretty remarkable. I can't even say
Yeah.
that at CCH all the
Right.
time. Um, we are plugged in with a local health team of some sort, usually nurses, case managers, some psychologists sometimes, that really help us identify next steps for a lot of patients. So I feel like over X many years that this group has been going down, they've really like created a relationship with the townspeople and um, healthcare team there that can make sure this person gets seen by a surgeon, or make sure this person finds a way to continue this medication that we're only able to give them, 30 days worth at that time. So that I think has helped my overall feelings about medical missions.
Yeah.
I think also along the way, that tenet of what we do, the first do no harm, is really something that's kind of evolved for me too. It is something that we don't, it's hard to separate, particularly as we're learning. Like we want to do all these things, we want to try to help this person, but if we make a cut on their neck and we're not there in 2 weeks to check on it, what are the bad things that can happen?
Certainly.
And it's similar to what we're doing on street medicine, I'd say as well. Some people I know will come see me the next week, and others I'm not sure when I'll see them again. What is the most helpful thing I can do? Um, you know, Risk versus benefit at that moment. So that's really evolved, I think, during my times going to Guatemala, especially.
Yeah, that I hadn't even thought about that last piece. I listened to an audiobook called War Doctor, and I've forgotten the physician's name, but he's um, a consultant physician in vascular surgery in the UK, and he spends a lot of time in conflict-ridden areas, places like Libya, even in Gaza, places like this that are um, seeing an exorbitant amount of emergent surgical um, cases. And his idea of medical missions has also evolved over time, where um, I think more and more people are recognizing this like white savior thing where you bring all of this good and then you take it away, and that does more harm than was intended. Uh, and so he's begun designing um, education programs for local physicians and local surgeons. Uh, is there, it sounds like there are more and more systems getting built to have this continuing care for the patients that you see maybe once a year. Um, are you are you seeing more resources to train up local Guatemalans to treat their own people? Is that something you would like to see? Um, yeah.
Yeah, I think so. The diseases that we saw there have changed in the last
Mm,
20 years as well. A lot more diabetes, a lot more hypertension. I struggle to remember, a couple people with diabetes when we first went, and now, everyone's on metformin. Um, I think sometimes, um, I don't think they have enough doctors in a lot of Central America. Uh, Cuba's an interesting place that will send out doctors. I don't know if you've heard or looked into that, but um, there are doctors, but I think they're underpaid, overworked. And but you know what? Some of what we do is just let people know they're on the right medications. There's this fallacy that the US has the best healthcare, and even if a patient has been appropriately treated, they'll come in and be like, "This is what I have," and you're like, "Oh, this is a med." We should start you on there, like, "Oh, I have that medicine. This is, like, this is my dose. Are you sure this
Yeah.
is what I'm supposed to be on?" And I think just the encouragement and confirmation that they're being treated appropriately. I mean, it's sad that they think that they need that uh verification, but sometimes that's what helps.
Yeah.
It's just like, it's the word I'm looking for. Validating.
Yeah. Yeah. How, so give us a picture of what a day in Guatemala or when you go down, how long are you spending there? And what does that time frame look like or time there
Trip
look like?
Trips are generally, so the ones I typically go on, I like to go with medical students. I just think there's, for various reasons, something just very gratifying of sharing this love of this culture, and trying to think outside the box, the medical bag that we're accustomed to assist this really neat population. Um, so, because it's through medical schools, it's usually 2 to 3 weeks. They often will do a week of like medical Spanish before going out into the medical work. So typically will join in for a week now, just with limitations. But we'll have like a debrief at the beginning in Antigua usually, which is a nice little colonial town in Guatemala that's kind of like an easing into of the country, really. And then the populations that we typically have served in the last couple decades have been around Lake Atitlan. Some of the people there, a lot of the people there still wear their indigenous suits. It's their
Or
everyday
their
colors. Yeah,
traditional
yeah,
garb.
their
Okay.
traditional garb. What color and pattern they're wearing is kind of lets you know what town or province they're from.
Okay.
It's pretty amazing. Um, and then there's Quiche or Cachiquel, different dialects of an indigenous languages that have nothing to do pre-Spanish getting there, and a lot of people only speak those languages. So, um, so we'll set up in a town in Lake Atitlan. That's like the more populated town. And then from there, we'll take buses or boats to smaller areas around the lake that often don't get that much medical care. There's not like a health center near them. We go out to them, have been for many years, going to many of the same places. So we load up big bags of medications, equipment. I typically go with osteopathic school, so they'll bring tables to do manipulation on. We've brought ultrasounds with us. depending on who's joining for different missions, sometimes we'll have a dentist, dermatologist, they'll bring different tools with them to help us out as well. And then we'll get to the small village. There's usually word that gets out a few days to a few weeks ahead of time to let people know. There's usually bells going off or sirens to let people know like when we arrive. We have a local team that usually helps us set up. So there's like a school or gathering center of some sort where we set up like a makeshift clinic for the day. And then we have a little table set up where we try to keep track of everyone that we're seeing. Amazingly, everyone, for the most part, has an ID card. A lot of times they'll bring vaccine records. And then we just kind of go through as many patients as we can. We set up little tables depending on what year the students are. There'll be like a preceptor to 3 or 4 students, sometimes less, if there's a lot of us. And then we also have someone translating. So sometimes it's from the indigenous language like Quiche to Spanish, and then sometimes Spanish to English, depending on who all is at that table. So it's an interesting, slower process, but usually see it say probably up to 100 patients a day, depending on the group and where we are.
Yeah, that's amazing.
Yeah.
How large is the team that you usually go down with of physicians?
I'd say there's usually somewhere in the vicinity of like 20 to 30 people, and that's usually students, physicians or other clinicians, as well as like community volunteers. I have a good friend who's now retired, but he was a firefighter, and he and his wife would always go down, and he would do some of the triaging or like lab work, and but his wife was always awesome at you know, being the check-in process as well.
Yeah,
So
that's really cool.
yeah.
Um, are you bringing down um, you mentioned lab work. Are you bringing down things to do blood work for like really routine labs?
Yeah, things that you'd think of that we can do in the clinic as like a
Yeah,
POC. So we check a hemoglobin, we would check urine. Trying to think if we did any other. I think we had an A1C at one point as well. Kind of depends on the year.
yeah,
But and then like glucose sticks, obviously. But
sure.
yeah.
And so, um, you kind of mentioned a little bit earlier how you're seeing the kinds of conditions you're treating are changing over the last couple of decades, and I imagine the needs of people in places like this are not altogether that different from the unique needs of underserved people in the US as well. And in large part, that's access to care at all. Does that ring true? Are you seeing like really similar um, needs, like access to dental work? Like in rural America, there's just a great lacking of specialists and dentists and dermatologists. And so primary care
100%.
doctors end up doing a lot more and end
Hmm.
up needing a lot more training. Is that also true in these places in Guatemala?
Definitely. And if they can get in to see someone, they can't afford the medication.
Right.
I haven't quite figured out what meds are sometimes covered. I know, I mean, largely they're cheaper there, which is great, but um, as here, people can't make $2 copays. They can't buy the antibiotic they were just told to get yesterday. So, thankfully, a lot of times we'll have that. We're in and out of the pharmacies that we can find down there as well. If it's something we don't carry, but this person really needs it. Um, we're making those kinds of stops as well. Um, and this is kind of like a mobile type clinic. I have been on other medical missions where there's more of a centralized clinic that we go help at, which is a little bit different as well, for different reasons. But but yeah, you're right. It's just a lot of times just access and poverty, that like here.
Yeah. Yeah. And that's fascinating to me. And in the same breath, it's also heartbreaking that it's such a pervasive issue. Not just the access to care, but the poverty component to that, where these people may be told this is what you need to get better, but they can't afford it, which is heartbreaking. And I think we see that so frequently with people where we work. Um, when you're in the 20 years you've been going down, have you had cases that you're seeing something very acute and you're very worried about this person? And if you do see that, what are you doing with that person?
Yeah, there have been a couple instances when we get an ambulance called in or we
Sure.
drive them to the nearest hospital, 'cause they need to be seen right away. I think the tougher ones are situations that are, they just involved more of like a team we'd have here, the case manager and a
Mhm.
therapist, and those are trickier and sadder to kind of walk away from, because you're not sure how it's going to end up. Um, I'm just thinking of a lady who was in a acutely bad state, and not safe at home, and it was really difficult to try to round up, you know, a therapist, a case manager abroad.
Right.
Whereas they exist, it was just asking 20 different people, and then you're trying to protect this person's privacy at the same time, and there's blurred lines, and just trying to get this person safe, and you're not sure of what resources there are. So those were, I think, trickier situations where it wasn't just get them to a hospital.
Right. Yeah, that's tough. And I imagine similar to rural America, these poorer parts of Guatemala don't have maybe the sorts of resources that we would have in the cities here, where we can get that person to a safe haven for
Hmm.
even just for the next night. Like they're gonna
Right.
have to go home to this unsafe place.
Hmm.
And man, what so one of the other pieces of this podcast is thinking about how the suffering that we make ourselves close to affects us. And so I guess I'm also curious, what does that do to you to hear this person say, I'm not safe at home, and the level of trust that that person and boldness to say that in the first place. Um, One, I think, is a tribute to you and your care team building a space that's safe enough for them to say that, which is huge. I don't think that's not that's not something everybody is capable of. So I think that's a huge indicator of the kind of person that you are and the kind of people that you go down with. Um, how how do you walk away from that, and what sorts of things, practices, meditation or something like that is what I end up doing. How do you walk away from that?
Um, I'm you have to place your trust in other people when you're,
Mm,
you know, and I think through the years I've become louder and knowing more about who I need to talk to get things done. And I have to take their assurances that they are going to do whatever they can. It's hard to pass that burden on to somebody else when you have to trust, and hope that it is going to the things that they said they might be able to do will happen. And it's tough to turn away, but there's two other people, waiting to also share their aches or burdens or, you know, other issues that we have to address that day. And what was oh my coping.
yeah.
Um, I think I think as far as medical missions go, I have seen happy stories, like people running up like the next year being like, remember you told me to go see this kind of specialist. Look, my neck is normal now or whatever. Or after you injected my knees, I could work, for like 6 more months. Can we do that again? So I think those little victories are amazing. And seeing students back on trips as attendings later on is another
Yeah.
little success story. And then I think for different reasons, I've returned to yoga, which I think that's why my hair is white right now. um, I think just, I feel like different forms of exercise, you can still get that monkey brain going, and you're just like, even though I'm running, I'm still thinking about XYZ that I have to do right when I get back. And I think yoga, you have to listen and kind of just get through that moment in whatever you're doing, that it kind of quiets your brain down a lot more than I find other forms of exercise do. Which sometimes is all we need to do, is just to take a little break from
Yeah.
what we're processing during the day, or what we can't process during the day.
Yeah.
So that
Yeah.
that's my
And
current coping right now. I did a lot of it in medical school, so I would recommend that.
okay. I'll definitely keep that in
um,
mind. I think
oh
I think
yeah,
of endurance sports in a similar way. Like
yeah.
maybe like running for a mile, I'll still be able to think, but once I get to like mile 8, it's like hard to think about what's going on, and all I can think about is, oh my gosh, I'm so tired.
So
uh,
maybe that's what I need to do, run
yeah.
further.
uh, I'll keep my thoughts to myself on that one. Don't hurt yourself. They say don't increase by more than 10% per week. So don't go from running a mile to running 8. So
No. I've gotten through a half a couple times, but I keep going back and forth if I have to do that marathon someday or not. But
yeah. Yeah. It's ooh, yeah. I don't know how I landed where I did with endurance sports, but I will say it has made me probably more in a similar way to how yoga has worked for you, to be more aware of your body and more um, able to take these moments while practicing yoga. And or for me, riding my bike up a mountain, I'm able to uh, take a beat, realize that at least in this moment, nobody's waiting on me. Nobody's like evaluating how fast I'm going. None of that matters. All that matters is one more push, one more breath, one more push. Um, and that for me has helped uh, get through the hard days, the the difficult things that come up in everyday life here. Or you go from doing these medical missions to doing just the easiest job ever, working with unhoused, underserved people in urban America. So I imagine that working in these practices with yoga is critical to being able to continue to do this kind of work.
Yeah. There's a someone I was chatting with. There's, tons of groups, especially Guatemala, that are going down, doing different types of work. But we got to a conversation about, how, what we were doing in Guatemala, and then he asked what I was doing in the States. And at that time, I was working at a different clinic for the homeless, but he was like, for the homeless, he's like, same church, different pew, and that just kind of struck something with me. I was like, yeah, that's probably is why both of those types of work, you know, call me or entice me. It
Yeah.
really is kind of similar work. I will say there are other types of missions that are different and I'd say equally gratifying, if not more. My sister was just on uh, a surgical medical mission in Zambia, and just the amount of people that got surgery that weren't able to is pretty astounding and
Yeah.
incredible. My husband's going on one in Guatemala in October, and I'm gonna stay back with the kids on this one, but
Hmm.
those are pretty incredible when you can just like instantly change someone's life when they didn't really have a hope of having that done before.
Yeah.
And then another one, which I encourage more people to do, was kind of alluding to what you were talking about, working with the team there um, in Tanzania. That's another cool part about these missions is that you make lifelong friends and these connections from all over the world that are just incredible people. There's a doctor there that actually grew up there and came to work in the US, but decided, that his lifelong dream was to make this little hospital in the middle of nowhere, just to provide more access. And so now he's created that, and there's missions there to help him out, giving back to his people, which is pretty astounding.
Cool.
Guatemala, there's another little hospital as well where we can rotate through, and that just, I think, has such a profound impact, a more lasting impact, I think, to really help
Yeah.
um, the teams that are, going through that all the time.
Yeah. Yeah, I mean, we're seeing even in the US these rural hospitals closing, and now there are massive, just an unthinkable number of people with such more limited access to
Mhm.
crucial care.
Yeah.
Um, and but to see someone taking it upon themselves to like bring that level of care to somewhere like Guatemala, or Tanzania, uh, to give back to these people in such a profound way is uh, that's very cool to see and meet those people and get to connect with them. Are you seeing a lot of the same physicians year to year on your missions down to Guatemala?
A lot of the same ones. Yeah.
Yeah, that's super
Yeah.
cool.
hmm And they'll tell you about other trips they're going on, and it's just really neat to see the different relationships and like different courses that allows people to take. One of the physicians we were on, who was on this last trip I went on, he met one of our other physicians that has been on the trip many times through like I think it was through a medical Spanish group, and so now this other physician, and they were both retired here, but they're just keep coming and helping, and it's just pretty neat, just the different stories people weave into each other. But
Yeah. Yeah, my grandfather was a family medicine physician in rural Nebraska
oh,
and ended up doing a trip down to Mexico and learned Spanish for that. And um, I know when I was in high school, uh, that was a pretty profound thing to hear. I would never have really guessed that about my grandfather. Of course, by the time I was born, he was already 80, and by
yeah,
this time, he was in his mid to late 90s and just talking about um, learning Spanish in his uh, late adulthood, like 60s, 70s, and then going down on these trips. And
that's
um,
amazing.
yeah, super cool. I think it takes a pretty unique person to go do these sorts of things, and I have a profound respect for that and for you, and I'm really grateful for you making the time to have this conversation. And um, yeah, uh, you're great, Leah. Thanks for
Oh,
joining.
thanks for doing this, Marshall. It's really impressive that you're doing all this before medical school even, and I'm sure it'll just keep evolving, and I'm excited to hear other stories.
Yeah, yeah.
Need to hear
There's
Ed talk always, but
yeah, yeah. He's gonna join for a couple more. That man is I when I joined CCH, it wasn't the job that I wanted. I got my EMT certification. I really wanted pre-hospital experience. Denver Health didn't want to hire me because I was still in school full time, and so I ended up just taking the CCH gig because it was all I could find. But and because of where I have worked previously in cabinets and in coffee shops, I was very skeptical when I first started working, and over time, uh, all of you have really helped me to bring those walls down and get to know you all in really meaningful ways. And it has helped me get back in touch with parts of myself that I didn't expect to. And I think that is not about me. Like that is about the people that I work with, and I don't even think it's about the organization so much as it is about the individuals there. And Ed has been there since the '90s. He has contributed a great deal to building the culture that's there, and
fine.
he's yeah, amazing. I couldn't ask for a better influence, and he's also got these very unique perspectives and looks into suffering and the willingness that you have to be vulnerable and share those perspectives. You, Ed, and all of the folks who have said yes to getting on is means a lot, means the world.
Oh, I think I mean, CCH brings different people for sure. And I kind of fell into work with the homeless as well. I didn't seek it out
Yeah.
myself. But then I think all of a sudden you're like, oh, this is what I'm supposed to be doing. But I think that provides you such interesting um, foundation to go into medical school with. Everybody has different experience before, some are even nurses before they go to medical school. But I really feel like our population and culture at CCH is just such a phenomenal. I mean, no, environment seems like not enough of a word.
Yeah. Yeah. I hear you. It's like the
It's
soil to build, to
yes,
grow out of.
yes.
Yeah.
Yeah. So I think it's hopefully you can continue remembering that when in those dark times in medical school occur.
Yeah. Yeah,
Um,
or the attending at the hospital is a jerk to
yes,
me,
yes.
and I just like harken back to Dr. Ed saying something that actually matters,
Totally.
instead of me
Hmm.
getting yelled at by some person who doesn't even know my name. So,
Yeah,
yeah.
exactly. You'll be like, something's going on with this person and it's not me.
Yeah.
You have you have these tools.
Thank you so much, Leah.